All right, welcome residents to today's explainer. I am literally so excited to walk you through this material because, well, obstetric anesthesia is just unlike anything else we do in the hospital. Treat this explainer like a comprehensive clinical shift. We're going to cover everything you need to know to safely manage the labor floor and the obstetric OR, going straight from baseline physiology right up to high-stakes emergencies. Remember, in this specialty, you are always caring for at least 2 patients at the exact same time, and your clinical decisions have immediate, profound impacts on both of them. Let's get to work.
Here's our agenda for today. 1. Core physiology and risks. 2. Fetal monitoring basics. 3. Labor analgesia techniques. 4. Cesarean section anesthesia. And 5. Managing obstetric emergencies.
Section 1. Core physiology and risks.
Okay, before we get into specific techniques, we have to establish the stakes. And remember our unique physiology here. Nearly all parenteral opioid analgesics cross the placenta, which completely changes our drug selection. But the ultimate bottom line of our specialty is right here: maternal mortality. By definition, this is the number of women who die during pregnancy or within 42 days following pregnancy termination, excluding accidents. I really want you to burn that 42-day window into your minds, okay? Our job absolutely doesn't end the second that baby is delivered.
So let's test your clinical reflexes with a scenario you're going to face practically every single day. You've got a patient scheduled for an elective cesarean section. She had a heavy meal earlier. What is the absolute minimum fasting requirement before you can safely proceed? Think about that full stomach risk that is universal in the pregnant population.
If you said 8 hours, you are spot on. And this perfectly illustrates a core rule of our practice. We treat literally all obstetric patients as full stomach risks because of delayed gastric emptying. For a light meal, the minimum fasting time is 6 hours. For a heavy meal, 8 hours. But we don't just rely on the clock, right? Aspiration is a massive, constant threat, so prophylaxis is mandatory. We're giving 15 to 30 milliliters of 0.3 molar sodium citrate to keep that gastric pH safely above 2.5. And if you're taking a high-risk patient back for general anesthesia, you've got to add H2 blockers like ranitidine and a prokinetic like metoclopramide. Airway safety is everything here.
Section 2. Fetal monitoring basics.
Now, let's look at how we monitor our second unseen patient to catch intrauterine asphyxia early. You are going to be staring at these fetal CTG monitoring strips for your entire career. Look at the relationship here between the maternal contractions on the bottom and the fetal heart rate up top. An early deceleration, where it basically mirrors the contraction, is usually just benign head compression. But late decelerations, the ones happening after the contraction peaks, huge red flag. That points directly to uteroplacental insufficiency and fetal compromise. And those sharp, abrupt, variable decelerations are telling you there's umbilical cord compression. If you see late or severe variable decels, you jump into action, change her position, get oxygen on her, treat any hypotension, and get ready for a possible emergency delivery. Section 3. Labor analgesia techniques.
All right, out on the labor floor, you absolutely must have these sensory level requirements memorized. They are highly testable, and practically speaking, you use them every single day. For the first stage of labor, it's visceral pain. You need a block from the T10 to L1 dermatomes. Once she hits the second stage and starts pushing, the pain becomes somatic via the pudendal nerve. So you've got to extend that block down to cover T10 through S4. And if we have to escalate to a cesarean section, you need to drive that sensory block all the way up to the T4 dermatome to blunt the surgical stimulation of the peritoneum.
So how do we hit those levels safely without causing a massive motor block? Synergy. It's basically a pharmacologic cheat code. When you mix a dilute local anesthetic, like bupivacaine, with an opioid like fentanyl, it significantly reduces the total drug requirement compared to using either one alone. You get amazing pain relief, she can still push effectively, and crucially, way less drug crosses the placenta over to the baby.
Okay, time for another clinical scenario. You're paged to a room. The patient is in severe, agonizing pain right at the start of early labor. She wants immediate relief and is thrashing around, barely able to sit still for your procedure. What is your go-to anesthetic technique here?
The answer? The combined spinal epidural, or CSE. This is literally a game changer for this exact presentation. You give a small dose of opioid and local anesthetic right into the subarachnoid space for super rapid, profound pain relief. Then, you thread in an epidural catheter to give continuous analgesia for the rest of her labor. It's the whole shebang, rapid onset from the spinal, plus the flexibility of the epidural.
Section 4.
cesarean section anesthesia.
Sometimes we have to escalate to the OR for a C-section. In modern OB anesthesia, we overwhelmingly prefer regional over general anesthesia because it directly lowers maternal mortality by avoiding failed intubations. When choosing between epidural and spinal anesthesia, it really comes down to the situation in front of you. Epidurals are fantastic if the catheter is already in place from labor. You can titrate the dose nicely, and it's great for post-op pain. Spinals, on the other hand, they give you a faster, much more predictable onset, a complete sensory block, and way less systemic toxicity since the dose is so much smaller. Pick the right tool for the job. But look, emergencies happen. If you have to do general anesthesia, your technique has to gotta be absolutely flawless. Step 1, position her supine with left uterine displacement. Use a wedge greater than 15 degrees to maintain venous return. Step 2, denitrogenation with 100% O2 for 3 to 5 minutes to build up that buffer. Step 3, rapid sequence induction with cricoid pressure. Step 4, you absolutely must confirm endotracheal tube placement before the surgeon even thinks about starting. And Step 5, extubate the patient fully awake to reduce that aspiration risk. Do not pull that tube while they're deep.
Section 5. Managing obstetric emergencies. All right, this is the climax of the shift. This is where your deep understanding of physiology saves lives. Hemorrhage is one of our biggest foes, so you need a solid framework. We split it into antepartum and postpartum. Antepartum bleeding, that's usually placenta previa, abruptio placenta, or a catastrophic uterine rupture. Postpartum hemorrhage, or PPH, is most often caused by uterine atony. The uterus just won't contract. If that uterus is boggy, you need to be aggressively pushing uterotonics, like oxytocin or methyl-ergovinine, and getting your massive transfusion protocols on standby.
Next up, severe preeclampsia. The classic markers, BP over 160/110 and massive proteinuria. We manage these intensely clamped down patients with magnesium sulfate for seizure prophylaxis, targeting levels between 4 and 6 milliequiv per liter. We highly prefer regional anesthesia here, but only if that platelet count is safely over 100,000. Now watch them like a hawk for magnesium toxicity. The earliest sign is hyporeflexia, which can quickly progress to respiratory arrest. If you see that, your immediate reversal agent is 1 gram of calcium gluconate IV over 10 minutes. Keep it drawn up. And finally, the absolute nightmare scenario, amniotic fluid embolism. It hits out of nowhere. Sudden tachypnea, cyanosis, profound shock, and generalized bleeding from every IV site. It triggers a devastating pathophysiological triad, an acute pulmonary embolism leading to right heart failure, rampant DIC, and profound uterine atony. You're going to need immediate, massive, multidisciplinary resuscitation, intubation, inotropic support, and uncross-matched blood.
So, as we wrap up this clinical shift, I want to leave you with a complex synthesis question to really mull over. Imagine your severely preeclamptic patient on a mag drip with platelets at 90,000 suddenly develops an amniotic fluid embolism and needs immediate intubation and hemodynamic rescue. How does the clash of severe hypertension and sudden embolic shock change your induction agents? What does her coagulopathy mean for your airway management? It's like a giant puzzle. Your ability to untangle these chaotic, competing emergencies is exactly what makes you an anesthesiologist. Keep studying, trust your physiology, and we'll see you on the next explainer.